Good evening. Hearty welcome to you all for the prestigious webinar series of Chess Council of India. Today, we have a panel discussion on a very important and a common clinical scenario, eosinophilic lung disease. In this context, myself and the co-panelists would like to thank CCI family, especially Dr. Ashish Dubey, President, Dr. Anil Maske, the General Secretary, Dr. N.H. Krishna and Dr. Narayana Pradeepa, CCI Chairman Trustees, Dr. Vijay Kumar Chetty, CCI Webinar Coordinator, for this great and wonderful opportunity. Eosinophilia is a common term, very familiar to all of us, probably one of the most common medical vocabulary in use. Often people equate eosinophilia with asthma, allergy, and almost all chronic respiratory issues. They are partly correct too, in the sense that eosinophil targets lungs very often. From allergy to autoimmune disorders, infection to inflammation, connective tissue disorders to cancers, the causes of eosinophilia are many. To discuss this issue, we have Professor Dr. Mahesh Mishra, the Professor and HOD of Respiratory Medicine at Mahatma Gandhi Medical College, Jaipur. Dr. Kamlesh Pandey, pulmonologist at Walcott Hospital and Inspire Chest Clinic in North Mumbai. And we have Dr. Devi Jyoti Dash. She is the Associate Professor and Consultant Pulmonologist, Sri Balaji Institute of Medical Sciences, Raipur, Chhattisgarh. We have Dr. Neel Thakkar. He is the Consultant Pulmonary and Critical Care Physician, Pulse Clinic and Sterling Hospital, Baroda, Gujarat. And Dr. Anand, Vardhan, Consultant Respiratory Medicine Specialist, Prakash Hospital, Noida. Before starting our panel discussion, we have two presentations. One is on etiopathogenesis and the classification of eosinophilic lung disease by Dr. Neel Thakkar. And second is management of eosinophilic lung disease by Professor Mahesh Mishra. Without much wasting time, over to Dr. Neel Thakkar for his first presentation, that is etiopathogenesis and classification of eosinophilic lung disease. Thank you.
Thank you so much for the kind introduction, and thank you Chest Council of India for organizing this webinar on eosinophilic lung disease and having me here as one of the panelists. Today we will be discussing specifically about eosinophilic lung disease, why and how. So what we want to discuss today is that what is the etiology and etiopathogenesis, and specifically what are the subtypes which we might be covering in eosinophilic lung disease. Eosinophil, which is one of the most important cells and the basis of our discussion today, was discovered by Paul Ehrlich in 1879, where he found that cells with granules, which he initially called as alpha granules, which had affinity for eosin. Alpha granule contents were secretory products and caused eosinophilia and were seen in asthma, various skin diseases, helminths, and also as reactions to medicine. As we can see in this figure, this is a eosinophil which has a bilobe nucleus, lipid bodies, primary granules, as well as the other parts of the cell body. Wilhelm Loeffler is the second celebrity academician that we should know about. In 1932, William Loeffler first drew attention to this syndrome where there was infiltration in the lung fields in the X-ray and eosinophilia as the main feature. The radiologic abnormalities are normally variable and may be migratory. However, he was the first to found this specific syndrome. So, eosinophilic lung disease is a heterogeneous group of disorders that share a feature of abnormally increased number of eosinophils within the pulmonary airways and parenchyma. Now, the definition was published in the Blue Journal in 1994, which said that there should be peripheral eosinophilia with abnormalities on the pulmonary imaging studies, increased eosinophil in the bronchoalveolar lavage, more than 10%, and lung tissue eosinophilia demonstrated in the transbronchial or open lung biopsies. Etiology, when we talk about eosinophilic lung disease, the first would be helminth infections, where the infections can cause either through transpulmonary passage of the larvae, as in Loeffler syndrome, pulmonary parenchymal invasion, heavy hematogenous seeding, or in tropical pulmonary eosinophilia. These are the ways by which helminth infections can cause eosinophilic lung disease. In immunology, in all these cases, there is sensing of parasite by the tuft cells, and the parasite products cause damage in the tissue as well as the goblet cells. There is an inflammatory cascade which is triggered by a number of interleukins which cause activation of the Th2 response as well as the B cell response and the subsequent mast cell degranulation and eosinophilic inflammation. So here the eosinophils not only act as protective, they are also part of the pathology itself. Ascaris lumbricoids, hookworms, and strongyloids stercoralis, all three can cause transpulmonary passage of these larvae and thus cause Loeffler syndrome. Normally, these larvae enter through the alveoli, ascend into the trachea, and then are again swallowed. Initially the eggs go in the feces, and these larvae then develop and penetrate the skin and enter the circulation, where larvae can then enter the alveoli and then again ascend in trachea, and the cycle continues. Diagnosis is by irritating non-productive cough, breathlessness. In sputum, sometimes eosinophil-derived charcoal-laden crystals are also seen. The opacities are normally migratory but become confluent more in the perihilar area and clear spontaneously. Definitive diagnosis requires detection of Ascaris, strongyloids, or the hookworm larvae, and stool is normally negative. These are the charcoal-laden crystals which can be seen in the sputum on stain. Pulmonary parenchymal invasion occurs with lung flukes such as paragonimiasis, which produce pleural effusion, as well as eosinophil-enriched inflammatory infiltrates. In the X-ray and CT scan, we can see the diagnosis is typically by presence of sputum or bile of the specific paragoniasis. There is nodular areas with surrounding ground glassing. Peripheral is more common, and middle and lower zones are more common. Cysticercosis, neurocysticercosis, as we know, has a dot sign on the CT scan where we can see this is the appearance. There is leakage and rupture of the pulmonary cysts of echinococcus or cysticercosis. This can also cause pulmonary eosinophilia. Antibodies can be demonstrated on ELISA as well as enzyme-linked electrotransfer blot assay. Hematogenous seeding of helminth larvae can also occur with deposition in the lung and with the pulmonary response. Such cases normally have a history of prior steroid use. Ascarids or hookworms such as Toxocara canis can also cause visceral or cutaneous larva migrans, which can spread in the lungs when large number of larvae are released in the bloodstream. Tropical pulmonary eosinophilia is very important and clinically relevant for us. There is distinct immune response to the blood-borne microfilarial stages of lymphatic filariae, specifically Wucheria bancrofti and Brugia malai. Organisms are usually spread by mosquito bites. Symptoms of cough, breathlessness, wheezing, fatigue, and fever. This is the lung where there is healthy lung compared to a tropical pulmonary eosinophilia lung, where we see there is lots of increased inflammation with increased in the toll-like receptors and cytokines, with increased antigen presentation, reactive oxygen species, degranulation, as well as higher inflammatory response. Diagnostic criteria: patient should be a resident where there is filariasis, blood eosinophilia, elevated IgE, as well as antibody titer, and clinical response to DEC therapy. This is an example of a case where there was over a period of 2 months response to the therapy. Pulmonary function test can also show in such cases a mixed restrictive or obstructive abnormality. Another scan where there is response with 2 months, 10th October and 7th November. Again, we see over a period of 1 month how there can be response in patients of tropical pulmonary eosinophilia. CT scans are very sensitive with nodular opacities, bronchiectasis, air trapping, calcification, or mediastinal adenopathy. Diagnosis is typically on respiratory symptoms, radiologic abnormalities, as well as area of residence, peripheral eosinophilia, high IgE, and elevated antiviral IgG antibodies. TB itself can also cause pulmonary eosinophilia, fungal infections, primary coccoidal infections, and infections can also manifest as community-acquired pneumonia 7 to 21 days after exposure. Importantly, medications and toxins. Sometimes asymptomatic pulmonary infiltration with eosinophils, sometimes chronic cough without any breathlessness, acute eosinophilic pneumonia, or even DRESS, that is drug reaction with eosinophilic and systemic symptoms can occur. So drugs commonly reported to cause DRESS include allopurinol, carbamazepine, phenytoin, sulfasalazine, antibiotics such as vancomycin, minocycline, dapsone, sulfamethoxazole, antipsychotics such as olanzapine, and amongst beta-lactam antibiotics are also reported to cause DRESS. This was one of the cases which was published in the International Journal of Molecular Sciences, where we see various skin lesions associated with DRESS. Toxin exposures, most important, the scorpion sting, heroin, even substances such as Scotchgard can also cause severe pulmonary eosinophilia-like syndromes. Other drugs such as heroin, crack, and marijuana can also cause this. This is a very important outbreak, the toxic oil syndrome. This occurred in Spain in the spring of 1981, where the commercial rapeseed oil was denatured with 2% aniline and was sold as olive oil mostly in the street markets in Madrid. This caused around, this 40 years from now, 20,000 people have been recorded, especially women with the age of 40 years, most frequently affected. There were at that time around 402 deaths from this. It can affect all organs and vessels, peripheral nerves, muscles, digestive tract, acute, intermediate, and chronic phase. Acute phase has a severe lung edema, eosinophilia, rash, and myalgia. Intermediate phase has dysphagia, cramps, severe myalgia, skin edema, pulmonary hypertension, major vessel embolism, and severe weight loss. In the chronic phase, there's skin edema, there is scleroderma, and definitely arthropathy later on, with neuromuscular manifestations as shown. Pancreatic and intestinal involvement have a very poor prognosis. The idiopathic acute eosinophilic pneumonia is a type of pneumonia associated with rapid development of respiratory failure, especially when we resume smoking, vaping, heavy exposure of smoke, fine sand or dust, especially common in military and firefighters. This is the classic overall appearance seen in such cases. Chronic eosinophilic pneumonia is idiopathic disorder characterized by abnormal accumulation eosinophils in the lungs, especially seen in women and non-smokers. Radiation therapy for breast cancer. Constellation includes cough, fever, breathlessness, weight loss, and night sweats. Peripheral eosinophilia is common but may also be absent. The appearance is classic photographic negative of pulmonary edema with bilateral peripheral pleural-based infiltrates, which are seen again on the scan and on the X-ray, which we can make out. Bile eosinophilia, more than 25%. Such nodular endobronchial lesions are seen. Histopathology or lung biopsy reveals interstitial as well as alveolar eosinophils and histiocytes with multinucleated giant cells. Eosinophilic granulomatosis with polyangiitis or the Church-Strauss syndrome is a vasculitic disorder characterized by sinusitis, asthma, prominent peripheral blood eosinophilia. The skin and the cardiovascular, GI, renal, and multisystemic involvement is there. Peripheral blood eosinophilia over 1500 cells is part of the diagnostic criteria, but much higher levels are common. The ANCA antibodies are found in less than 50% of these patients, and pulmonary involvement, and when present, most of the time it is anti-MPO pattern. Transient patchy infiltrates, and it may not have lobar or segmental distribution. This is the classic palisading granuloma of eosinophilic granulomatosis with polyangiitis with necrobiosis, disintegrating neutrophils and palisading in the center, as we can make out. Such is the appearance. ABPA, again a very common entity, is complex hypersensitivity reaction that occurs when airways become colonized with aspergillus. Repeated episodes of bronchial obstruction, inflammation, and mucoid impaction leads to bronchiectasis, fibrosis, as well as respiratory compromise. The immune response elicited by Aspergillus are responsible for this syndrome. The ISHAM criteria, where you have a predisposing condition such as asthma or cystic fibrosis. The obligatory criteria of IgE levels against Aspergillus fumigatus as well as raised total IgE. Other criteria such as precipitating antibodies, radiologic opacities, and total eosinophils more than 500 are also criteria for ABPA diagnosis. There can be CT scan which shows proximal cylindrical bronchiectasis with upper lobe predominance and bronchial wall thickening. And this central bronchiectasis with normal tapering of distal bronchi is classic sign of ABPA. Multiple dilated third and fourth generation bronchi can also be seen. Small peripheral bronchi with mucus plugging are also seen. Other miscellaneous causes of pulmonary eosinophilia include hypereosinophilic syndromes, where there will be systemic involvement with pulmonary involvement, eosinophilia more than 1500, association of hypereosinophilia with eosinophil-mediated organ damage, and pulmonary symptoms are seen in majority of these cases. Other conditions such as IPF, sarcoidosis, and HP can also be associated with eosinophilia. Before I end my session, Dr. Mishra will be getting into all the management aspects. This is an important table where, based on the duration, history, lab findings, and CT findings, we can make out what is the likely cause of the pulmonary eosinophilia and will help us in the overall management of the patients. So I end my talk today with words by Paul Ehrlich, the person who discovered the eosinophil. And we need to recognize that even rare diseases such as the toxic oil syndrome was there. And even there are eosinophils besides the asthma cases. There has a lot of other causes where pulmonary eosinophilia is there. It's very important to identify and treat such causes. And thank you so much for joining on this festive occasion of Janmashtami. Wishing everyone a happy Janmashtami and Hare Krishna. Looking forward to the very interesting panel discussion that follows. Thank you very much.
Thank you, Dr. Thakkar, for a beautiful talk on treative pathogenesis of eosinophilic lung disease. Thank you, Dr. Shahjahan, for a nice introduction. I am going to take on management of eosinophilic lung disease. I start my talk with a case discussion. A 60-year-old male having complaint of shortness of breath, cough, peripheral blood film show eosinophilia. On examination, patient had bronchi. We have chest X-ray. You can see chest X-ray. Classical finger and glove appearance. PFT show revisible air obstruction, suggestive of bronchial asthma. Total Ig was 9500. IgG and IgE was positive. CT scan show patchy area of consolidation with ground glass opacity, with bronchiectasis, with mucus plugging, giving finger in glove appearance. The CT features was suggestive of allergic bronchopulmonary aspergillosis. So, the patient was put on corticosteroid and patient responded well to the medication. Total Ig was decreased by the 50% by the end of 3 months. Now, eosinophilic lung disease is characterized by the presence of peripheral blood eosinophilia, typically more than 500, associated with radiologic evidence of pulmonary disease, supported by more than 10% eosinophil ball, and histopathologic evidence of lung tissue eosinophilia. Current treatment approach for the eosinophilic disease is directed as underlying cause when identifiable cause or urgency of treatment guided by the severity of involvement of the organ. When cause is unknown, treatment is directed at largely on eosinophilic directed therapy. Now, ABPA is one of the commonest eosinophilic disease, which we encounter in our day-to-day practice. It developed due to hypersensitivity reaction to Aspergillus fumigatus or other Aspergillus species in the airways. It is characterized by the peripheral blood eosinophilia, increased total Ig level, and IgE and IgG specific to the Aspergillus antigen is usually positive. The treatment is OCS alone or with combination with the antifungal drugs are also effective for the patient with ABPA. Omalizumab, mepolizumab, benezumab like biologics have been tried. Several case reports are available in the literature and there is several small case results. So this is the table showing patient of ABPA was treated with biologics. You can see maximum number of patients treated with omalizumab. It was found that these biologics are effective in treating the difficult ABPA patient. They were able to suppress the relapse. They were able to reduce the dose of OCS. There was improvement in the pulmonary function. There is improvement in the radiographic finding. There is minimal side effect of the biologics. Only one local side effect produced by the omalizumab. That is that do not require any kind of treatment. Coming to Lafleur syndrome. Lafleur syndrome is considered simple pulmonary eosinophilia, self-limiting disease. Symptoms are usually mild, non-specific. Physical examinations are usually unremarkable. There may be some rhonchi. No specific therapy for the simple pulmonary eosinophilia is needed. It usually resolves within a 2 weeks. Seldomly needed corticosteroid to control the symptoms. Now come the tropical pulmonary eosinophilia. Symptoms are non-specific. It should be doubted in person come from the endemic area. Chest X-ray may be normal, may present with bilateral uniformly distributed mottling, or mottling become confluent, giving the appearance of pneumonia. PFT may show obstructive and mixed pattern. Diagnosis is usually clinched by peripheral blood eosinophilia between 3 to 500. Total Ig is increased. Final antibody tests were positive. Treatment is diethyl carbamazine 6 mg per kg weight in divided doses. It can be given up to 4 weeks. Relief occurs within a day. Although hematolo-radiologic abnormality may persist beyond a month. Now come to the chronic eosinophilic pneumonia. CEP and idiopathic parenchymal diffuse lung disease that characterized by marked accumulation of eosinophils in the alveolar space and etiology is unknown. Symptoms are usually moderate to severe, non-specific symptom, fever, cough, shortness of breath. X-ray are usually of photographic negative pulmonary edema. CT scan may show peripheral space consolidation. Diagnosis usually classical clinical radiological. So immediately corticosteroid can be given. Duration of treatment is 3 to 6 months. Lesser the duration, higher the possibility of relapse. Relapse also well respond to the corticosteroid treatment. Now, what comes to the refractory chronic eosinophilic pneumonia? It is defined as repeated relapse and requiring oral corticosteroid maintenance therapy were estimated to around 20% of chronic eosinophilic pneumonia cases. Biologics are used for off-label for CEP. So there is no robust report analyzing efficacy of biologics in a patient with chronic eosinophilic pneumonia. Majority of patients with chronic eosinophilic pneumonia treated with biologics are initiated because of their refractory disease or their persistent or frequent relapse disease and adverse effect of the oral corticosteroid. And the person who refused to OCS therapy, biologics monotherapy, is administered as a initial therapy or for the relapse cases. Now we can see the cases of chronic eosinophilic pneumonia treated with biologics. These are the omalizumab, mepolizumab, or benalizumab. The maximum number of cases treated with mepolizumab of CEP, but they were able to achieve symptom control, they were able to suppress the relapse, they were able to reduce the oral corticosteroid dose, pulmonary function was also improved, radiographic finding was also improved with the biologics. Now, acute eosinophilic pneumonia, it is acute febrile illness, less than 5 days of duration, hypoxic respiratory failure, diffuse alveolar and mixed alveolar, it is shadowed the chest X-ray, ball having more than 20% of eosinophil, and absence of any other cause of eosinophilia. A prompt response to steroid, a failure to relapse after the discontinuation of the steroid, usually 2 to 4 week steroid is enough, taper over the next 4 weeks. Now, coming to hypereosinophilic syndrome, it is a rare heterogeneous disorder characterized by persistent peripheral eosinophilia, around 1500 for the at least 6 months, and evidence of end organ damage or dysfunction. Clinically often overlap with eosinophilic granulomatous polyangiitis. Clinical manifestations depend upon the affected organ. In general, pulmonary symptoms are in more than 40% of hypereosinophilic syndrome. 50% of the hypereosinophilic syndrome respond to the high dose steroid. Other drugs are hydroxycarbamide, cyclophosphamide, azothioprine, interferon alpha, cyclosporine, and etoposide. Now, EGPA, formerly known as Chagusha syndrome, it is a rare form of ANCA-associated vasculitis that presents with eosinophil infiltration in the tissue and with clinical representation of the vasculitis. Diagnostic criteria are proposed by the Lanham with the eosinophilia more than 1500 and vasculitis involving 2 or more extrapulmonary site. Other criteria was given by the American College of Rheumatology. 3 point for the obstructive disease, 3 point for the moderator multiplex, 5 point for the eosinophilia more than 1000, 2 point for the extravascular eosinophilic predominant inflammation on the biopsy, -3 and -1 point for the CNCA and hematuria respectively. When more than or equal to 6 points are obtained, the sensitivity and specificity were 85% and 99% respectively. The mainstay of EGPA therapy is use of corticosteroid. Cyclophosphamide is also effective for the inducing remission, but it should be avoided in active non-severe disease due to toxicity. Adjunctive immunosuppressive agent is recommended to lower the corticosteroid therapy. The maintenance of remission can also be achieved by the methotrexate, azothioprine, and mycophenolate. Intravenous immunoglobulin often are demonstrated in peripheral neuropathy, not in the remission. Now, coming to the refractory EGPA, it is a persistent active disease despite of appropriate course of immunosuppressive therapy, vasculitis with life-threatening manifestation like alveolar hemorrhage, glomerulonephritis, central venous vasculitis, multiplex, cardiac involvement, meningeal ischemia, etc. Now, FF score. This score include renal efficiency, J tract involvement, cardiomyopathy, ENT parameter, and age more than 65 years. FFS 1 is often used as definition of severity, or FFS 0 is a definition of non-severe disease. Now coming to the refractory disease, EGPA treated with the biologics. These are the ongoing trial, phase 3, phase 4, phase 3, phase 2, number of trials are going on. Primary outcome is reducing the dose of oral corticosteroid. Secondary outcome are usually adverse effect. So these results are quite promising. Hope we'll get some more data in future as a result of these trials. So, thank you very much for the presentation. Thank you very much.
Thank you, Dr. Neel Thakkar and Professor Mahesh Mishra, for the wonderful presentation, which made our job easy. Many of the questions in your mind have already been answered by your presentation, but still, we'll go with the panel discussion because a repetition will help us to know better, especially these kind of issues are being discussed often, but still we remember we forget to many of the things, what to do, when to do, how to do all these things. So let us start my first question with Dr. Kamlesh Pandey. You please define eosinophilia. What is eosinophilia? People are talking about eosinophilia often, but what is eosinophilia scientifically, and what is hyper-eosinophilia?
Yeah, yes, sir. Before defining, I would just like to make and this thing that this is my first presentation at CCI, and I would like to thank all the CCI family, Dr. NH Krishna, Dr. Atri, and all the CCI family, and you too, sir, for guiding me to discuss this topic. Now, before defining eosinophilia, I would just like to touch upon the basic biology of eosinophils, which is a granulocytic, which is a WBC of granulocytic lineage. Again, predominantly it is there in the tissues and not mainly in the blood. Predominantly it is in tissues, and on activation it is capable of injuring the lungs, parenchyma, airway by releasing mediators. Now, eosinophilia is better defined by the absolute eosinophil count, which is actually total WBC into percentage of eosinophils in the this. Now, AEC of usually in normal person, it is less than 500 cells per microliter. Pulmonary eosinophilia is absolute eosinophil count of more than 500 per microliter, along with a radiological abnormality, that is pulmonary imaging abnormality in X-ray or CT, or in terms of bronchoalveolar lavage, there is more number of eosinophils, or lung tissue demonstrated by transbronchial or lung biopsy, the demonstration of eosinophils in the lung tissue. So this is pulmonary eosinophilia. Then the definition of hypereosinophilia is absolute eosinophil count of more than 1500 cells per microliter in peripheral blood on two different occasions taken 1 month apart. And along with that, pathologic features of eosinophil in the tissues. Now, hypereosinophilia definition was that, but what is hypereosinophilia syndrome is whenever there is hypereosinophilia along with end organ tissue damage due to eosinophilic inflammation, when other causes of eosinophilia have been ruled out.
Thank you, Dr. Kamlesh, for the wonderful answer. On hearing your answer, I feel you are a seasoned speaker, not the first speaker. Anyway, thank you for the very good answer, right answer. So my next question is to Dr. Anand Vardhan. We already discussed during the talk, what are the intracytoplasmic granules of eosinophil, and what are the specific proteins released by degranulated eosinophils? Dr. Anand Vardhan, please.
Sir, at the outset, I would like to thank CCI family for giving me this opportunity. Just like Dr. Kamlesh, it is my first webinar with CCI.
Okay, all the best.
Okay. So, sir, eosinophils primarily are a class of granulocytes. So, they contain two classes of granules. One is primary granule, which is seen in the progranulocytic phase, wherein they are in common ancestry with all the other granulocytes. And when they differentiate in the myelocyte stage, then they have secondary granules. So these secondary granules contain several vesicles. So these vesicles contain major basic protein MBP, then eosinophilic peroxide EPX, and then eosinophilic cationic protein ECP, and eosinophilic derived neurotoxin, that is EDN. And apart from that, it has got lipoid vesicles, which contains chemokines and icosanoids. So as we know that icosanoids carry out the cycle for formation of various inflammatory mediators. Apart from that, chemokines, including eotaxins, help in chemotaxis of eosinophils to the site of inflammation. And now coming to the degranulation part of it, sir. So as we know that degranulation is triggered of eosinophil is triggered in several ways, with the recent studies suggesting that there are proposed four mechanisms. Rather, there are four different mechanisms through which the eosinophils degranulate. So one of the mechanisms is a cytolysis, which is non-apoptotic cell death, which happens in case where there is an injury to the cell, but it will release the vesicles in toto. Then we have the most peculiar type of uh, degradation, which is piecemeal degradation. In this, what happens is for a specific receptor, the attachment is there, and then a specific vesicle only will be released, which is now being tried in various therapeutic interventions. And then we have two types of every cell releases vesicles by exocytosis. So it has also got a mechanism of exocytosis as well as the mechanism of compound exocytosis. So this compound exocytosis occurs when there is a receptor also particularly, and the membranous vesicle also releases as a part of natural exocytosis. So significance of all these mechanisms is various types of receptors, and it is explaining that why different eosinophilic disease have different manifestations. So it is actually, sir, a lesser studied part. Today only I was going through the extensive literature, and they say that still there is a lot of work to be done, because MBP was characterized to be anti-parasitic, and now it has also been given a role in antibacterial. So various types of protein, which namely I told major basic protein, eosinophil cationic protein, eosinophil peroxidases, and eosinophil derived neurotoxin, which causes neuritis and which you will be seeing in EGPA and all. So there, all these have been studied actually using knockout mice, and sometimes they behave differently in human beings. This is what has been documented. And I just missed on part of primary granules. Primary granules have two things, and one of them is Charcot-Leyden proteins. So Charcot-Leyden proteins are important because they have been the identity of eosinophils since past 150 years, but now we have come to know that these are not specific to eosinophils because they are in progranulocytic stage. So
Okay. Anyway, you explained the sophisticated mechanisms beautifully. Now, after first time is my next question is to the professor. Professor Mahesh Mishra, we have seen so many pneumonias. So when will we suspect eosinophilic pneumonia? And also tell us how to pick up this pneumonia in clinical practice, especially in the early setting. No, as you correctly mentioned, if you are diagnosing these conditions much late, it is of no use. So how will you early pick up these cases, and when will you suspect these pneumonias?
Dr. Shahjahan. Basically, eosinophilic pneumonia, until unless you have your this entity persists in your mind, you cannot pick the diagnosis of eosinophilic pneumonia. What is important that all the respiratory diseases have a non-specific symptom like fever, cough, shortness of breath. They are all have non-specific symptom. Whatever pneumonia they all have fever, all will have cough, all will have shortness of breath. So you have to pick. You have to pick by the clinical history first. Almost you have to pick the history. You have to pick history of asthma. And once you got history of asthma, clinical finding asthma with chest infiltrate, asthma with chest infiltrate. So you can doubt of this patient maybe of eosinophilic pneumonia. Then asthma, chest infiltrate, and supported by the peripheral blood film eosinophilia. These are the few points which can give clue that this may be the patient of eosinophilic. Once you have history, once you have chest X-ray, once you have peripheral blood eosinophilia, then you take complete history about any drug he have taken, any endemic area which he have traveled, recent past, about everything you have to take in pictures. Complete clinical picture, including history, chest X-ray, and complete blood count. Once you have chest infiltrate and pulmonary eosinophilia, then you doubt chest infiltrate along with the peripheral blood eosinophilia. Then you doubt just this patient may be of eosinophilic lung disease. Then you have to investigate further. Further to find out the cause of the eosinophilic, like CT scan, like bronchoscopy, like immunological workup, like IG, total IgE. But you have to doubt that this patient may be here peripheral eosinophilic lung disease.
Thank you, sir. Okay, sir. Continue, please.
Just majority percent in our endemic country, we feel that everything is tuberculosis. We feel that everything is chest infiltrate. In the Indian scenario, we feel this is the tuberculosis. Majority percent we encounter, especially of ABPA, was put on, has a history of prior history of anti-tuberculosis drug. When you have migrating infiltrate, when you have classical appearance of fingering glove appearance, when you have classical appearance of photographic negative of pulmonary edema, when you have classical mottling middle lower zone, these are certain radiologic features which give clue to the diagnosis of eosinophilic pneumonia.
Thank you, sir. Naturally, we are stressed on history, which is a forgotten art. So we have to be very careful on history. A thorough history is the key to diagnose not only eosinophilic diseases, the most of our respiratory diseases, not only respiratory diseases, in clinical medicine, history is still very, very important. So now we will go on to Dr. Devi Jyoti Dash. You just tell us what is classical eosinophilic pneumonia and how we can differentiate acute eosinophilic pneumonia and chronic eosinophilic pneumonia.
Thank you, sir, for the question. And I want to thank CCI and the whole team for giving me this opportunity. So talking of eosinophilic pneumonia, the classification has been very well told by Dr. Neel, where we divide it into primary and secondary forms. First, primary, if the lung is only involved, mostly in simple pulmonary eosinophilia and idiopathic acute and chronic eosinophilic pneumonia. Secondary can be because of drugs, toxins, or various parasites. Okay, so now coming to classic eosinophilic pneumonia, which can be divided into acute and chronic eosinophilic pneumonia. So how do we differentiate between them? Acute eosinophilic pneumonia, as the name suggests, has an acute presentation, mostly within 5 to 7 days and a maximum of 30 days. It has severe pulmonary symptoms, which often ends in respiratory failure. We get patients in ICU. Many of them are mechanically ventilated. Again, it is mostly observed in middle age, like 20 to 40 years of, and has a male predominance. And especially when they start smoking or there is a change in smoking behavior, acute eosinophilic pneumonia is mostly found. We can get nodules, we can get ground glassing in X-rays and CTs. The most striking feature is we have bronchial aspirate eosinophilia more than 25%, but peripheral blood eosinophilia is markedly absent. This is a very important point, and there are few studies which show that if there is peripheral eosinophilia in acute eosinophilic pneumonia, the prognosis is good. It has a milder course. Now coming to chronic eosinophilic pneumonia, as the name suggests, it is a chronic form of pulmonary symptoms of cough, breathlessness, mostly over months, mostly in patients of eosinophilic asthma. It has a longer course, milder course. It has marked bronchial aspirate eosinophilia, obviously more than 25%, but often we find percentage of more than 40 to 50%. It has marked peripheral eosinophilia, and it responds very well to steroids. The classical CT finding is photographic opposite of what we find in CHF, and we find peripheral ground glassing, subpleural ground glassing. It is more common in young women.
Thank you, Dr. Devi, for the clear explanation of the or differentiating idiopathy, acute eosinophilic pneumonia, and chronic eosinophilia. Now, Dr. Neel Thakkar, you please one more explain us what is toxic oil syndrome. You already explained, but please once more.
Thank you, sir. I'll just take the toxic oil syndrome question, sir. Just one point to add to what Dr. Jyoti had described, that in any acute eosinophilic pneumonia, the presentation is very much, the definition also is very much like Berlin definition of ARDS. Yes. Everything is same. The only thing is BAL eosinophilia more than 25%. Even the photographic negative of pulmonary edema, what you have been seeing in the last 2-3 years in the COVID pandemic, the peripheral ground glassing, pura frank shadows which we see in COVID. So my point being that in the acute presentation, a lot of times in ARDS, we are told that steroid is like in most of the septic shock guidelines, in most of the critical care guidelines, we find the role of steroids only limited to septic shock. But this is one place. So again, why BAL eosinophilia is where again systemic steroids will be helpful in acute eosinophilic pneumonia. So that is one point I just wanted to add. Second, regarding toxic oil syndrome. So again, I described in my slides in 1981, there was in Madrid in the streets, there was the oil which was manufactured. There was denaturation with 2% aniline. Rapeseed oil was contaminated. So there in the street markets, in the food olive oil which was used, that contaminated olive oil spread throughout the almost 402 deaths happened that time. So that was because of the contamination and persistent inflammatory response with multisystemic response. So acute, intermediate and late 3 stages were there, and initially involved the lungs and the skin. So pulmonary edema-like features with breathlessness, skin rash, skin reactions were there. Gradually, the process overall went towards vasculitis with gradual fibrosis involving the lung parenchyma as well as the liver involvement was also there. And in late stages, there was arthralgia or myalgias were also very common with neuromuscular involvement. So this was even still from that date till now, 40,000 people have been affected with toxic oil syndrome, and it continues to be localized in that one particular area. So again, as Dr. Mahesh Mishra sir had explained, that the importance of history. This was found because somebody noticed history में ऐसा कुछ oil सब साथ में ले रहे थे. So that is why otherwise everyone would be on lines treated as asthma only. So that is why this is a very good example in history why even such the etiology or the history remains very important. Thank you.
Thank you. Now again, the question is back to Dr. Devi. See, we have so many drugs available for these conditions, but still we rely, most of the time we rely upon steroids. Why we are considering steroids the most important drug, and how steroid works?
Yeah, so sir, in mostly as we are discussing eosinophilic lung diseases, so eosinophils are mainly a marker of allergic inflammation. They are produced by hematopoietic stem cells, and then activation and maturation occurs by various mediators of Th2 lymphocytes. So steroids cause eosinopenia, as we have seen in almost all our patients of eosinophilic asthma or TPE or other eosinophilic lung diseases. So how do they do it? They decrease the production of eosinophils from the bone marrow and also increase the sequestration and apoptosis of eosinophils. So as we Indians also, we say that steroids are the Ramban we have. Like any eosinophilia, many patients come to us that I have eosinophilia. It is very difficult to make them understand that eosinophilia is not a particular disease. It is just a manifestation of various diseases, and many a times people don't get diagnosed and they are just taking steroids because the symptoms are better because of the eosinopenia or decrease in eosinophils level caused by the steroids. So I think that is very important. The steroids cause remission in eosinophilic lung diseases.
Absolutely. So now this is the era of biologicals. My questions to Professor Mahesh and Dr. Neel Thakkar is, what is your experience with the use of these fascinating names like omalizumab, mepolizumab, benralizumab, dupilumab, etc. in eosinophilic lung diseases? And what is the difference between these agents, if you find any?
Can I take?
Yeah, so, sir, what is your experience with the monoclonal antibodies in eosinophilic lung diseases?
So regarding my experience treating with eosinophilic lung disease with monoclonal antibodies, very few in this car.
Yeah, because most of the time you can manage
as far as literature is concerned, that the many case report, case series are available with these monoclonal antibody. Literature say that monoclonal antibody should be used. Most of the monoclonal antibody was used when the patients were reluctant to take OCS, old corticosteroids. There was side effect which are unacceptable to patient, like diabetes mellitus, something which. So they use the biologics. They found that biologics are effectively reducing symptoms, reducing the dose of corticosteroid, effectively improving the radiologic findings. They are also helpful the improvement of the pulmonary function also. There are a lot of case series are available. There are a lot of ongoing trial with the biologics are there. So they say that that's very basically biologics is upon new era of therapy for the eosinophilic lung disease, especially those are like hypersensitivity syndrome, eosinophilic cholangitis. They are relatively poor prognosis compared to the other eosinophilic lung diseases, especially when they still required for the long-term treatment like chronic eosinophilic lung disease. They require around 3 to 6 months of steroid. We all know steroid can cause various side effects, and biologics are also used in the eosinophilic cholangitis. So they found very effective reducing the dose of steroid as well as controlling the other disease.
Okay, sir. So, Dr. Neel, you want to add something on these eosinophilic depleting agents? You want to add something?
Yes, sir. So basically, sir, among the biologics, the ones which I have used, one has been omalizumab, which we have been using earlier on also with refractory severe eosinophilic asthma cases. In one to two cases, I've used mepolizumab, which has recently been used. But again, there has not been a classic chronic eosinophilic pneumonia, which have been like persistent high BAL eosinophilia, which has been there. It is more for the more severe asthma cases, which have been having severe peripheral eosinophilia, where again, I have had anecdotal experience, but from like what Dr. Mahesh Mishra sir has said, that the main use is to cut down on the steroids and the secondary systemic effects of the steroids and to reduce the number of relapses, and especially for refractory severe cases where सब कुछ दे दिया पर फर्क नहीं पड़ रहा, तो उस केसेस में once you've treated the cause, you've done lung rehab, सब कुछ कर दिया, still you need additive options, and where cost is not an issue, or cost, like there is some even assistance programs with most of these biologics now. So in such cases, these molecules will definitely be helpful. Literature defines criteria as chronic eosinophilic pneumonitis, ABPA, even Church-Strauss syndrome cases. There have been, again, there is no RCT. Whatever literature, there is no randomized control trial, there is no meta-analysis. Whatever is there are case series. Because of the cost and the implications, this has not been studied in a very large data. However, once these do come, we would want more and more molecules, because ज़्यादा molecules आएगा तो automatic cost down जाएगा, and we'll have more options to use them in practice. But it is a definitely promising future for chronic eosinophilic pneumonias where more biologics can be used. Thank you.
Well said. So at present, we are not in a position to compare and contrast these various agents. That is the.
Sir, so basically, again, the studies, whatever have been done, amongst them, mepolizumab has been the most highest amongst the eosinophilic pneumonias. And compared to dupilumab, mepolizumab and bendalizumab have been more studied. But again, cost is the big problem which restricts their use.
These are Western. Most of them are Western studies, and we should have our own data.
Definitely.
So as of now, we are not in a position to compare or contrast these various agents at present.
Individual molecules.
Okay. So we'll go to the other area. So next question, next issue, Dr. Kamlesh. What are the imaging findings of ABP? It's a very simple question, but many of our viewers are postgraduates. They wanted to know what are the imaging findings of ABP.
Yes, most of the things was covered by Dr. Neel Thakkar.
Based on CD findings.
Yes, sir. Thank you, sir. Most of
the question to Dr. Neel again.
Yeah, Dr. Neel already described ABPA. Even Dr. Mahesh in his presentation described ABPA, lots of findings of ABPA. Again, going back to basics, it's a complex hypersensitivity reaction in response to aspergillus fumigatus in patients with cystic fibrosis or bronchiectasis, asthma. So again, imaging findings in terms of chest X-ray, we can get findings of parenchymal opacities, atelectasis due to mucoid impaction, bronchiectasis, findings of bronchiectasis like tram line, parallel lines, ring shadows, toothpaste shadows, finger in glove shadows, perihilar opacities due to mucus plugs. So all these are the findings on the chest X-ray. In terms of HRCT findings, what classically we see is proximal bronchiectasis, central bronchiectasis that is within the two-third in the center, with upper lobe predominance, with mucus plug, tree invert opacity, sometimes with endobronchial infection, airspace consolidations also can be found. Because it's an airway disease, there is mosaic attenuation. But the classical feature of ABPA is the high attenuation mucus plugs. That is very classical of ABPA. Bronchiectasis could be a cylindrical bronchiectasis or saccular bronchiectasis or varicose bronchiectasis. The different types of bronchiectasis can be seen. The characteristic finding in ABPA is the high attenuation mucus plug, which has high density of more than skeletal muscle in terms of its attenuation. And mainly why this is high attenuation is there because of mineral components in the fungal elements and the mucus. There is mineral components which lead to high attenuation of this mucus plugs. Again, this HAM is associated with higher chances of relapse in ABPA. So it is also has a prognostic marker. And the classification of ABPA in terms of the HRCT findings are that it is divided into 4 types. The first is ABPA serological, in which the HRCT findings, the classical HRCT findings are missing. Second is ABPA bronchiectasis, in which we get the classical central bronchiectasis, upper lobe bronchiectasis. Third is the ABPA HAM, which what we described, high attenuation mucus plugging, which is a very characteristic and classical feature of ABPA. And last one is ABPA with chronic pleuroparenchymal fibrosis. Again, in this condition, there is parenchymal fibrosis, there is scarring, there could be fibrocavitatory lesions, there could be aspergilloma, there could be pleural thickening, and all those things. Many times it is difficult to differentiate this condition from a post-TB sequelae patient. So this condition, the last one, is difficult to differentiate it from the chronic post-TB sequelae.
Absolutely. Thank you. So the next issue is that how will we manage ABPA? What is the role of steroids in ABPA, and also what is the role of antifungals? And if we are planning to use antifungal, which antifungal? Dr. Anand, please.
Thank you, sir. Am I audible, sir?
Yes.
So, sir, basic treatment of ABPA, as all the esteemed panelists and most of our viewers know, that the mainstay is basically on 2 things. One is corticosteroids. Off lately, with the recent evidence, they have added antifungals, and the last thing is inhaled corticosteroids. So as we know that inhaled corticosteroids do not impact the disease activity per se, but they are of very important. They play a very important role in the control of the asthma associated with ABPA. So asthma control is taken by ICS, higher dose of ICS, that is equivalent to 1600 microgram of budesonide. And then now coming to the mainstay of the therapy, which is corticosteroids. So corticosteroids, multiple regimens have been proposed, and there is no robust RCT done which supports any one regimen. But there are two regimens which are in vogue. One is a low dose or medium dose regimen. Another one is a high dose regimen. So in medium dose regimen, we start off with 0.5 mg per kg per day for first 2 weeks. Then we switch the same dose for an alternate day for 6 to 8 weeks, and then we taper 5 to 10 mg per week. So ultimately, the entire therapy will last somewhere around 5 to 6 months. Then another regimen is high dose regimen. High dose regimen has 0.75 mg per kg per day, and then you taper, you come to 0.5 mg per kg per day for another 6 weeks. So first 6 weeks 0.75, another 6 weeks 0.5, and then we taper again 5 to 10 mg per week, and then over 6 to 12 months, it is spread over 6 to 12 months. So after various studies, they compared these high dose regimen with medium dose regimen, and most of the studies says that they are equally efficient. So then obviously for avoiding side effects of steroids, more preferred regimen is a medium dose regimen, unless we are not getting a response. Then after that, sir, they have also tried pulse regimens, which are still under evaluation. Many of the studies are going for pulse regimen, in which they are giving 10 to 20 mg per kg of IV steroids for 3 days a month, and that is to continue for 6 months. However, this is under evaluation. So as per treatment part is concerned, medium to high dose regimen is what is in use. Another thing is addition of antifungals. So as we know that ABPA pathology mentions there is a reaction to the ABP fungal proteins. So elimination of fungus is what is the purpose of antifungals here. So as all of us know that antifungals, we have options of itraconazole, voriconazole, posaconazole, isavuconazole, but obviously for all the practical purposes, and the most tried and tested is itraconazole, most user friendly, and it has passed most of the trials. So it is 5 mg per kg per day. For a 60 kg, it will roughly translate to 300 mg OD. Sometimes we can convert the dose to BD if you are not getting the desired therapeutic response. So this therapy can go on for 3 to 6 months. Again, for steroids as well as antifungals, there is no defined timeline for ABPA. Basically, all of it is case studies which have shown improvement, and more or less we have taken the endpoint as such. And I am sure that all the esteemed panelists are seeing these cases day in and day out, and they must have their own experiences with the finishing line of the therapy. So what they have mentioned is it's 3 to 6 months of antifungal therapy. In antifungal therapy, they have said that since we all know that itraconazole impacts the LFTs, so LFT should be done at 0, 1st and 3rd. That is, start at the therapy 1st month and 3rd month. Then coming to the other options. So voriconazole, when it was tried, it is not actually approved by US FDA for children less than 12 years. So we have extrapolated the same, that in children less than 12 years, in which CF can present with ABPA, so there voriconazole cannot be used because safety has not been tested. Then coming to posaconazole and isavuconazole, obviously they are for more resistant cases, expense is very high, and there are no trials, large trials supporting them. Then just I would like to add a few words on biologicals. I too have very limited experience with biologicals in ABPA, but biologicals have been tried in many studies, and there are many ongoing trials going on with omalizumab, mepolizumab, and dupilumab, and benralizumab as well. So, however, in one of the cases in Safdarjung Hospital, in my final year of SRship, we were using it in one of the patients. I couldn't follow the patient for a longer period, but in 4 to 6 months, she was not getting much improvement despite giving steroids and antifungals, but she had symptomatically improved with omalizumab. So it's a kind of anecdotal evidence at the best.
Okay, clear. So we will go on to eosinophilic granulomatous polyangiitis. So Dr. Kamlesh, what is the diagnostic criteria in eosinophilic granulomatous polyangiitis in the pre-ANCA era, and what the type of EGPA you know?
Yeah. So again, EGPA, the eosinophil rich. I'll first go to the definition of EGPA. There is eosinophil rich necrotizing granulomatous inflammation, often involving the respiratory tract, and necrotizing vasculitis of medium to small blood vessels associated with patients of asthma and eosinophilia. So asthma and eosinophilia is the baseline, and along with that, there's necrotizing inflammation of the vessels and eosinophil rich inflammation. So this is the this is the definition of EGPA, or the Churg-Strauss syndrome, previously known as Churg-Strauss syndrome. Again, first diagnostic criteria was described by the Lanham criteria, which included asthma, blood eosinophilia of more than 1,500 cells, and evidence of vasculitis into 2 or more extrapulmonary organs, and all 3 criteria had to be fulfilled. Then the next diagnostic criteria came in by the ERS, in which it was included that asthma and eosinophilia forms the baseline. Along with that, any of the 4 parameters should be fulfilled. So first was definite vasculitis features like biopsy-proven vasculitis. Second was supportive evidence of vasculitis like urine analysis suggestive of dysmorphic erythrocytes, red cell cast, proteinuria, leukocytoclastic changes. And third is mononeuritis or polyneuropathy. And next is ANCA associated and ANCA positivity and systemic manifestations of EGPA. So out of 4, any of these 4, if any one was present, then it was EGPA. It was defined. It was diagnosed as EGPA. There was another criteria by Mira, which was for trial purpose. I won't go into the detail of that. The importance of this ERS criteria was that it did not include the ANCA negative EGPA, and they proposed that hypereosinophilia with systemic manifestation for these patients who had ANCA negative vasculitis. So next, again, this was all the definition. Then there was classification, which was covered by Dr. Neel in the initial lecture. There was the first American College of Rheumatology classification, which included asthma, eosinophilia, neuropathy, polyneuropathy, and extravascular involvement. And presence of any 4 of these parameters were used to distinguish ABPA from other vasculitis. So the classification was to distinguish this EGPA from other vasculitis. And the latest was described by Dr. Mahesh, the ACR 2022 criteria, which was given, the markings were given for obstructive airway disease +3, which was described by Dr. Mahesh. A score of more than 6 was suggestive of EGPA.
Okay, thank you. I think we have to go a little bit hurry because so many questions from the audience are waiting. So, Dr. Devi, we know the controversy, the Montelukast and EGPA. And also someone says inhaled steroids, use of inhaled steroids, use of omalizumab all precipitate EGPA. You just tell us or some light upon what is the current scenario, what is the current scientific evidence?
So basically, as we know that the main etiopathogenesis of EGPA is still not clear. It may have ANCA positive, it can be ANCA negative. It is put under vasculitis also, it is put under eosinophilic pneumonia also. And the organ damage is caused by eosinophils and also by the vasculitis caused by ANCA. So coming to the causes, there are two school of thoughts. One school of thought is that many drugs may precipitate EGPA when used in asthma cases. But the most common explanation for that is that because of the use of montelukast in such patients, there was a decrease in oral steroid use, which was masking the effects or presentation of EGPA, and thus, because of the unmasking, EGPA has been precipitated. Similar is the case with inhaled corticosteroids and omalizumab. Because of the use of omalizumab, when the dose of steroids were decreased, many persons had precipitation. But the other school of thought, and there are many studies, and most of them are actually case studies or case series, not many prospective clinical studies. So they say that omalizumab can be used in diagnosed EGPA.
Okay, thank you. You correctly said it is the masking effect. That is probably that is also the correct, because people when start on montelukast may reduce the dose of steroids or vice versa. That kind of inhaled steroid, whether it is inhaled steroid. And with regard to omalizumab, we are not in a position to comment at present, but still there are so many conflicting reports. So the next issue is that a very common issue, that is tropical pulmonary eosinophilia. Our professor has already said it can be self-limiting, but when it needs treatment with the steroids, and when we recommend actually. So Dr. Neel Thakkar, please comment on that.
Hello.
Yeah.
Yes. So, sir, tropical pulmonary eosinophilia, number one, like in India itself, when we think of cases where there is a subacute course. So one was acute, less than 7 days with bile eosinophilia. So when there is a subacute course limited from weeks to months and the symptoms are persisting, and patient lives in an endemic area where the filarial infections are common, such as Wucheria bancrofti or Bugia malaria are common. In such cases, we see that patient has been treated on multiple antibiotic courses and still has multiple fleeting or migratory opacities in various x-rays, that it is resolving, again worsening, again improving, and there is with that raised IgE levels. In such cases, these are probably the subset where you will think that this patient could be one having a tropical pulmonary eosinophilia. You will go for antivirarial titers to identify that specifically this is present or not, and based on the residential area, if the patient fits into these criteria that this patient is likely to have tropical pulmonary eosinophilia, you will give a trial of diethyl carbazine. Now, you will not wait for, again, in such cases, even in the diagnostic criteria of tropical pulmonary eosinophilia, there is the response to DEC. So, a lot of times we wait for reports ki nahi, we want definitive diagnosis ho jaye. But in a lot of settings where you know that this is very common, in such times, even response to DEC is one of the criteria. So, in such cases, these are the candidates where tropical pulmonary eosinophilia will need treatment with DEC. Steroids are an adjunct to the treatment. They are not the primary treatment. The primary treatment remains DEC. Steroids are indicated in an acute setting, and for the primary treatment, for suppose a patient has underlying asthma or needs bronchodilators, the inhaled steroids definitely will help with reducing the inflammation. But systemic therapy with steroids is not the primary therapy with PPE. It is an adjunct therapy. It is a supportive therapy. So this would be where we could, the way ahead with tropical pulmonary eosinophilia.
Okay. Actually, I am also from Allapuzha, where the filarias was very common. But now it is less. But when we were undergraduate students, all of us get at least some filarial edema and stuff like that. So at that point of time, this tropical pulmonary eosinophilia was very common in this place. But as Professor Mahesh said, it is self-limiting most often. But at times, people used to take steroids, and not only people take heterosan, also people used to take in at earlier days. Anyway, that was the treatment at that time. Okay, so we will move on to the next issue. So, Dr. Anand Vardhan, what is hyperinfection syndrome? And you tell us which parasite is likely to cause it and what are the consequences?
That hyper infection syndrome was a name given to accelerated infection by Strongyloides stercoralis. So,
Exactly.
as we know that this worm has a life cycle in soil as well as in the human host. So the infective form of this worm is falciform larva, which comes through the skin, then through the capillaries to the alveolar capillaries, then to airways, through airways after coughing, and swelling of that sputum to GI tract, and then in GI tract it again proliferates and becomes a rhabditiform larva after molting, and then it basically is excreted in stool and again back to the soil. So this is what is the usual cycle. There is a impediment to this cycle, which is auto-infection, like if the larva starts migrating from the GI tract itself or through the people with poor hygiene from perianal skin, again it can come back. So when this auto-infection is accelerated, it can result in hyperinfection syndrome. This was what was defined in many places, but in CDC, they defined it again that for all practical purposes, a diffuse form of strongyloides and hyperinfection syndrome should be treated as the one and the same thing. So basically, there is an increased load of larva migrating to various organs, and then it will create symptoms as per the organ which has migrated. So this organism has its life cycle in GI tract as well as the respiratory tract. So in respiratory tract, it causes alveolar hemorrhage, hemopsis, cough, dyspnea, ARDS-like features. And then in GI, it can cause gastrointestinal obstruction, nausea, vomiting, diarrhea, constipation. Anything can occur according to the area which is has infested. Rarely, it also migrates to the nervous system, causing meningitis. And uh, apart from these features, if it migrates to any unusual organ, that several case studies have reported, so it presents as any worm infestation as such.
How will
So,
you manage?
sir,
How will you manage?
Sir, if the symptoms are, we treat it as per the symptoms actually. Making a diagnosis of hyperinfection syndrome, well, we'll trace it from the history that whether the patient is on long-term corticosteroids or is immune suppressed in any manner, basically. Uh, First thing, it will give us hint that whether the patient is having or he's coming from that kind of area. So then, first thing is that then upper GI endoscopy can be done. Duodenal biopsy can demonstrate the work or aspirate taken from that. Then BAL also has demonstrated in several cases the presence of the strongyloides worms. Serology can be misleading many a times because serology has a cross reaction with other helminths. So it will come positive with the other helminths infection also. So then, sir, whenever it is ARDS, so it is basic management of ARDS by mechanical ventilation if needed, and a broad spectrum antibiotic because the patient is already immune suppressed. And then the definitive treatment comes from ivermectin, which has to be given 200 microgram per kg per day for which will be roughly 12 milligram tablet for every day for a duration of time wherein we have negative stool samples or the negative sample whichever we have taken for 2 weeks. So
Exactly.
this is how they have described the treatment. I do not have personal experience of treating any hyperinfection syndrome, sir, as such. So I just saw that endpoint is that only.
But that is the standard treatment. No doubt that is the treatment. So I would like to announce that there are 882, that is 882 logins right now. So a big congratulations to CCI for conducting this session in a regular manner. That is why people are logging, because we know that nowadays n number of webinars are there. Now we have login 882 logins are there. Thank you, CCI. So the next question is to Dr. Devi Jyoti. We know that eosinophil, we heard about the grading eosinophil. Eosinophil is more than 500 cubic millimeter. But what about BAL sample eosinophilia? What is the cutoff? You please tell us.
So normally in BAL samples, eosinophils shouldn't be there. If at all they are there, they should be less than 1% in normal individual. For diagnosing eosinophilic pneumonia, the cutoff is 25%. If eosinophils are more than 25%, we can think of acute or chronic eosinophilic pneumonia as per the condition of the patient. Mild rise in BAL eosinophilia may be caused in ILDs like PLCH, sarcoidosis, or with pneumonia in AIDS patient, or with some drugs. However, more than 10% eosinophils should raise suspicion of eosinophilic lung diseases.
Absolutely. Thank you. So, Dr. Neel Thakkar, now we know that we are using a lot many drugs for many a condition. Not only we pulmonary physicians, there are people using a number of medications for various conditions. So drug-induced eosinophilia is a very big problem nowadays. You just can you enumerate what are the common drugs which can cause eosinophilia, and in what clinical settings, especially the clinical settings are many. What clinical settings you expect drug-induced eosinophilia more often?
Sir, so again, the place when we suspect drug-induced is when we have ruled out the other causes, whatever we have discussed. So if there is an acute setting, the causes of acute, if the patient has not immediately left smoking, chronic eosinophilic pneumonia, ABPA, these are all the classic histories and presentations we have discussed. So when we find that the patient history is not matching these, और we find that नहीं IG positive नहीं है, patient को तो भी persistent eosinophilia है, and you have ruled out all the systemic infective as well as non-infective causes which could be there, and there is a definite multiple comorbidities for which patient is on a particular drug, then in those cases we should think about a diagnosis of exclusion as drug-induced eosinophilic lung disease. As an example, in cases where you have a patient who is on multiple long-term NSAIDs or non-steroidal anti-inflammatory drugs, allopurinol is very common. Second, recurrent antibiotics. The patient ko, for some reason has been taking minocycline for long. Patient has been a CKD patient who is needed vancomycin, has been using since a long time. These are some antibiotics where beta-lactam antibiotics also, eosinophilic lung disease is common. Anxiolytics is also one group, that carbamazepine, oxcarbamazepine. These are both very common drugs which are routinely prescribed. So anxiolytics can also cause eosinophilic lung diseases. So more important message should be that it should be a sort out. Definitely drug history has to be elicited, but the drug diagnosis has to be the first one. First, we have to rule out the systemic and the clinical causes. If we are able to rule out, then drug, so I described DRESS in my presentation. So drug related with systemic symptoms. So that is the presentation when you have skin manifestations with eosinophilia in an unexplained cause. So again, in those cases, we can find drug related eosinophilic lung disease. Thank you.
Again, you are also trusting on history. Of course, history is the key. So that many of our newer doctors, younger generation has forgotten. So history is very, very important. So, Professor Mahesh sir, could you please explain us the clinical interplay between asthma, vasculitis in EGPA? Because we are seeing many asthmatic patients, asthmatic symptoms, urticarial symptoms, allergic rhinitis symptoms in EGPA. So, can you please elaborate us on this interplay between these conditions and EGPA?
Yeah. Basically, patient with EGPA having a history of a late onset of asthma. What has happened that when they or basically diagnosis of EGPA can be delayed by the due to the therapy of systemic steroid which is being given in the patient of asthma during exacerbation. So these because of these steroid because of this steroid during asthma treatment can delay the diagnosis of EGPA. So patient who are having late onset asthma, having symptom of extrapulmonary involvement, should we look for the EGPA?
Okay, sir. Thank you. So now the question is to Dr. Anand, sir, regarding idiopathic hypereosinophilic syndrome. You tell us what are the echo, because we all know that hypereosinophilic syndrome, the cardiac involvement is so high. Tell us what are the common echo findings in idiopathic hypereosinophilic syndrome.
Yes, sir. So as we know that classical M type of or rather myeloid type of HES has more of cardiac involvement, and lymphoid has more of cutaneous and skin involvement. So if we are suspecting or if we have diagnosed the myeloid type of HES, then what we are expecting to find in 2D echo is due to the prothrombotic stage promoted by this disease, there is obliteration of the apex of uh, both the ventricles. More commonly, left ventricle is obliterated by presence of a laminar thrombus. Then other most common finding is, since there is a lot of eosinophilia followed by thrombosis followed by fibrosis, it causes basically endomyocarditis, and which eventually results in restrictive cardiomyopathy. So second common thing which we'll find in the 2D echo of HES, idiopathic HES, is restrictive cardiomyopathy with a E by A ratio of more than 2. Basically, so filling pressures will be higher once we scan such a patient. Then we have mitral valve regurgitation, because mitral valve is the most common valve which is going to be involved. And another thing is there is a differential shortening or a lengthening of chambers. So any valve can be involved basically. But most common to get involved is mitral valve in case of hypereosinophilic disorders. And there is also valvular thickening in which the individual leaflets of the valve get thickened. And again, in this also, the maximum brunt is borne by mitral valve only. So in order, mitral valve, tricuspid valve, and last to involve is pulmonary valve. Apart from that, sir, few of the case studies have also reported presence of pericardial effusions, and in just very few cases, tamponade has been reported, but it's very rare actually.
Okay, thank you. So we now know that many of these pulmonary eosinophilic diseases are associated with extra pulmonary symptoms also. So, Dr. Devi, what are the common extrapulmonary involvements in EGPA?
Yes, sir. EGPA, as per the classifications, also we know that there is vasculitis, there can be ANCA positivity. So the other organ involvement can be divided into because of the eosinophilia or because of the vasculitis or the ANCA. So most commonly, heart and the GI is because of eosinophilic damage, and the vasculitis part affects other organs like the nervous system, peripheral or central nervous system, skin, or other. So coming to the most common extrapulmonary organ involvement will be GI, where the patient can present with acute abdomen with abdominal pain. There can be pancreatitis, diarrhea, or things like that. As the cardiac manifestations has already been described by Dr. Anand as pericarditis, myocarditis, conduction defects, etc. Now coming to the most common thing which we talk is the neuritis part. Mostly peripheral nervous system is involved. It can have mononeuritis multiplexa. It can involve polynerve many nerves also. Most common nerves are peroneal, tibial, median, and ulnar nerve. In extreme cases, central nervous system can also be involved with stroke or subdural hemorrhage, etc. Next, coming to skin involvement. Skin involvement is mostly in form of purpura or nodules. So these are the few extrapulmonary symptoms.
Okay, thank you. So now it is time to discuss the questions raised by our audience, esteemed audience. Dr. Ujjal Kumar Bose has commented, I would like to know about this disease. We have already been discussing and discussing is going on. And Dr. Ramamurthy asked the differential diagnosis. Again, I think that question also we answered in detail. Dr. R.S. Panway asked about the presentation in children. Anybody want to say, in short, what is the presentation of these eosinophilic lung diseases in children? It is just like asthma, allergic rhinitis. Yeah. Okay, Devi, if you want. Okay, please. Oh, continue. Start.
Sir, secondary causes are common in children. Primary causes are not so common in children. Whichever needs longer duration, like chronic eosinophilic pneumonia or EGPA, which needs long-term asthma. So those are not common in children, but secondary causes like parasitic infection, drugs, toxins, all these are very common in children.
Exactly. So Dr. Prakash Kalap from Maharashtra asked what are the common eosinophilic lung diseases in elders, children below 6 years? That I think we have answered.
One comment here just for the children, that in cases where specifically bronchiectasis, a lot of times when you have children with cystic fibrosis, they may present with bronchiectasis with recurrent infections, and also patients who are atopic who have recurrent secondary infections. Those are also one in the children population which might be there.
Yes, if you are not addressing it properly in time, especially. And another question from Dr. S.K. Toke from Maharashtra. Please comment on drug-induced lung diseases. That is before our question being asked to the panelists. It is already been discussed in detail. Thank you, Dr. Toke, for asking such a question. Then another question, I think sputum eosinophilia. How useful is sputum eosinophilia as a surrogate marker of BAL eosinophilia now? It was quite popular in 70s and 80s. Further, BAL may not be available at periphery. Anybody? Sputum eosinophilia is a wonderful choice, but as he said, there are limitations. Anybody? Neel, Thakkar, please.
Sir, basically, we again here the Barter score will help us that in normally just understanding whether there is a good quality Bartlett score. That is the score when we use to identify a good quality sputum specimen. So if there is no increase, the epithelial cells are very less in number and the quality of sputum is very good, and you have a good differential count, the machine where and a good pathologist who is able to differentiate properly, then sputum eosinophilia even till date in cases where you are not able to get a BAL, that is a good investigation. So, but you should have a good pathologist and the Bartlett score should be of a good specimen from inside. It is still useful, especially for asthma phenotypes. Eosinophilic, neutrophilic, and response to inhaled steroids, that is a very good test to still help us in identifying that therapy.
You said it.
I would want to comment that it is difficult to even get sputum eosinophils even in good centers. So it is
only research centers. As a part of, if a PG is committed as part of her study, then only it is possible. Otherwise, it is very, very difficult actually.
Yeah.
So Dr. Ashish Sinha from Bihar asked, what about IgE if IgE and the eosinophils are high? Obviously, only if eosinophils are high, we consider it as eosinophilic lung diseases.
And
obviously, IgE might also be good, but the value of IgE alone, I think IgE is being overused. The serum IgE is anybody come with CSR, my IgE is high. So I think that is not that much relevant. We have to go in a schematic fashion, or else we may overdiagnose many of these eosinophilic lung diseases. Then I think no more questions seen in the chat box. So before winding up, I should thank all of the panelists for their vibrant presence, also CCI family. Before winding up, I should ask one question to each and every one that will come in my mind. If you please be short, answer each. All the panelists need to answer. So we find out there is eosinophilia, maybe moderate eosinophilia, more than 1,500 per cubic millimeter. But the person is all right, no pulmonary involvement. That is asymptomatic eosinophilia. Your opinion on that?
So I would like to evaluate the patient even if there is no pulmonary involvement. There can be.
Okay. Sir, please, Professor Mahesh.
Yeah.
I think you heard the question. Okay.
Your question is asymptomatic eosinophilia, right?
Absolutely asymptomatic. But you find out that the eosinophil count, one person come to you with, sir, my eosinophil count is 1,600 per cubic millimeter. You have extensive investigation, no findings other than eosinophil.
Sir, basically, we should take complete history. History is a basic requirement for any starting any treatment, and we should not treat reports. We should treat patient first. We should not reports of eosinophil. That's my take.
Thank you. Yes. Brilliant opinion from the professor. Dr. Kamlesh?
Yes, sir. Sir, I would like to repeat the eosinophil count from another lab.
Okay. Dr. Devi?
Sir, I will not ignore a report of say 1600 absolute eosinophil count, but I will evaluate the patient. But if I don't get anything, I may keep under observation.
Dr. Anand?
Sir, I will repeat the test, but after a month or so. If the patient is symptomatic, he won't have any issues in repeating after 1 month. So I will repeat and see. If it is still high, I will still go for investigating him further then.
Absolutely. Dr. Neel?
Sir, I would agree with Dr. Mishra, sir, that if the patient doesn't have a problem, it's an incidental finding. I'll highlight, put a sticker, put it in the file, record it, but I will not investigate the patient further in absence of any symptoms. However, next time that report, the older report is important if the patient comes up with any other systemic symptoms, that this patient is a patient of an undiagnosed eosinophilia, and compared to that, how severe is the eosinophilia, and then we trace and investigate. But just, I think, number one is the ethical part of it, and number two is the medical part of it. So first of all, if the test is done, but it should not be like investigated just because of the test. Problem hai to test karne ka further, otherwise we record and keep it. Yes.
Exactly. Even the guidelines do not recommend it in clear-cut fashion whether to treat or not to treat. Still, the controversy is going on. Anyway, we had a very beautiful discussion over this very important topic. Still, many areas are uncovered because eosinophilia, eosinophilic lung diseases, big area. Even ERS monologue contains some more than 200 pages. So it is very, very difficult. So I request all the PGs present here to read about eosinophilia. And on behalf of all the panelists, Professor Dr. Mahesh, Dr. Devi, Dr. Kamlesh, Dr. Anand, Dr. Neel, I thank CCI and also to all the audience for this giving us this wonderful session and also your questions, active discussion, etc., etc. Thank you all. Good night.